Okay, I hope everyone can hear me. Thank you very much for the introduction, and thank you very much for inviting me to be part of today's session. I'm very privileged to be here. I think MND New South Wales do a fantastic job, and it's great to be able to come to an event like this and I suppose impart some of my knowledge on motor neuron disease. My association with motor neuron disease probably goes back now at least for the last 6 years. It was something I had an interest in during my neurology training. I spent time with the MND clinic at St. Joseph's Hospital, and I continue to spend some time there. My PhD was on motor neuron disease, and now my research work is still on motor neuron disease. So 3 days out of 5, this is the condition that I think about and I'm working on. And as a clinician, I suppose I have that expertise with seeing patients and then translating some of the work into research. So it's really something that I'm very keen on. In terms of the disease itself today, I'll try and present an overview about the actual condition, what motor neuron disease is, how it can affect people, talk a little bit about the medical terminology, the symptoms, the medications we use, future directions, and there is time at the end of my talk to ask me questions. Certainly happy to take any questions, and I'll try my best to answer them going forward. So in terms of motor neuron disease, it is a relatively rare disorder, but in saying that, it's an important disorder. And I think we are finding a number of people presenting to us, and with the Ice Bucket Challenge, and I think with the increased awareness of the condition, certainly we're seeing patients presenting to us very early on. And I think it's a good thing, and I think in part it's because a lot of general practitioners and other specialists are more aware about the condition. The incidence is thought to be 4 to 8 every 100,000. I don't think there's any clear evidence that it's increasing with time, but as patients get older, and we've got an older demographic in terms of the Australian population, we will see it more commonly. So generally it's a condition you tend to see in patients over 40, 50 and 60. The male to female ratio is such that perhaps it affects males slightly more than females, but not to a large degree. So really we tend to see both males and females presenting with the disease. It's, in terms of the presentation, it is largely a sporadic disease. What we mean by that is whilst there are some patients who have a genetic history, so they may have affected first-degree relatives, by and large, when you look at the family tree, 8 out of 10 individuals, there is no underlying gene that we're aware of. So it makes it a little bit challenging because we do not know who's going to develop the condition. The mean age of onset is 56, although it does vary quite remarkably. So in some cases we've seen people in their 20s, in other cases we've seen people in their 80s. So there is a broad range of people who can be affected, but generally it affects people in the middle, mid-century, right? So in their 50s usually. The average disease duration is 3 years, but this varies greatly. So when you look at the large studies, they've suggested that that's the average time frame, 3 to 5 years. But depending on the type of disease, depending on the individuals, it can range up to 10, 15, 20 years. And certainly we've seen people living for that long with the condition, which is very good. And it's certainly, it's good to see that. In terms of the classical onset of the disease, the vast majority of patients present with limb-onset disease, whereby patients will have weakness or symptoms attributed to an arm or a leg. That's the usual presenting complaint with motor neuron disease. However, in an important 20 to 30% of patients, the symptoms may be confided around the mouth and the bulbar region. So they may present with difficulty with speech, difficulty with eating and swallowing. So these are usually the patterns that you see in MND. And over time, they can progress to go up to involve the bulbar regions, or from the bulbar regions, they can come down to involve the limbs. The disease was first described by a very famous neurologist, Charcot, over 150 years ago. So it's been around for a long time. And he diagnosed the condition based on pathological studies, on autopsy studies. So over 150 years ago, he was looking at a microscope and identifying that there was changes both within the brain and the spinal cord. So in medical terminology, we refer to that as involvement of the upper and lower motor neuron axis. And that's important, and I'll come back to it later, because there is conjecture, and still at this stage, we do not know if the disease starts at the level of the brain or involves the motor neuron in the spinal cord. And this is important. It's important because if you're going to try and target therapies, you've got to know where you're going to focus your attention. If you don't know where the disease starts, it's going to make it harder for you to try and treat the underlying condition. So this is an important point, and I will talk about this more during the course of my presentation. In terms of the diagnosis of the disease, we tend to utilize features of lower motor neuron dysfunction, whereby patients may have weakness, they may have twitching of the tongue. We might use nerve conduction studies or needle EMG testing to diagnose the condition, along with combination of upper motor neuron findings, where you might have brisk reflexes. You see the doctor or the neurologist, they tap on the reflexes and they're very brisk. You might find there's spasticity, so muscles are very stiff and sore. And you find these other upper motor neuron findings. So when patients present to us as a clinician in the rooms or in the hospital, we're relying on a combination of these findings to make the diagnosis. This is important because in motor neuron disease, really it is a clinical diagnosis. There is no one magic blood test, there is no one neurophysiological test or an imaging test to make the diagnosis. It is really a clinical diagnosis whereby the neurologist looks at the patient, examines them, hears the story from the patients and their family members, and then tries to tie it all together. The diagnosis of motor neuron disease was first formalized over 15 to 20 years ago, and it was called the Escorial Criteria. And at that stage, really, that was the pivotal diagnostic criteria because it helped to sort of compartmentalize how we diagnose patients with motor neuron disease. We started to use the terms possible, probable, and definite. And to a certain degree, we still do that. So when we see patients very early on with the disease process, they may only be possible, and the reason we use those terms is because of these diagnostic criteria. About 10 years ago, the criteria were revised and they were called the Awaji Criteria after a consensus meeting in Japan. And with these criteria, it was hoped that we can try and diagnose patients earlier. So the real goal is, I suppose, when patients come and see us, we want to try and give patients a conclusive diagnosis as early as possible. One of the challenging issues with diagnosing motor neuron disease is the uncertainty. And I think that's something that's very common and may be shared by a lot of people here today, that for a lot of time you feel that you're seeing one doctor and you're getting referred and you're waiting to get the diagnosis. And the difficulty is it's because it's challenging to diagnose. But these criteria try and aid in the diagnosis, and there are constant revisions that are being made to try and improve diagnosis early. The issue generally, however, is as neurologists, we very rarely want to get the diagnosis wrong, right? So it may well be that we might hesitate, we might follow patients up over a few months until we can really confirm the disorder, but you don't want to get the diagnosis wrong. And I think that's the most fundamental issue with motor neuron disease. Really, it's a diagnosis after exclusion of all other disorders. So if I was speaking to my registrars or if I was teaching fellow doctors, I would have another table now where I would list all the other possible neurological mimic disorders, and I would advise them that they've got to go through that list meticulously to make sure that patients don't have any other reversible condition which you can treat promptly and potentially fix. In terms of an important part of the diagnostic test, the nerve conduction studies do play a very important role. And I'm sure a few of you may well have had this, whereby you've got the stimulation of the nerves, you're recording over the hands or over the feet to try and ascertain whether there's involvement of the motor neurons or the sensory neurons. And if the sensory neurons are involved, that would suggest another disorder. So generally, in motor neuron disease, the vast majority of patients have what we call motor symptoms, weakness, and I'll come back to the other symptoms, but they shouldn't have much in the way of any numbness. They can do, and occasionally there could be another diagnosis to explain it, but usually numbness, burning, tingling, that's not a classical complaint we see in motor neuron disease. So this testing, the nerve conduction study, is important, because if we do see that, then it raises a few possibilities about other diagnoses. One of the tests that we do with the nerve conduction study is a test called a needle EMG assessment. It's not pleasant, But, we use a needle, we inject, or not inject, we sort of insert into a few muscles around the body, looking for these sort of changes on the computer screen. So you've got the nerve conduction study, I'm sitting there as a neurologist, I've got the needle, I'm putting the needle in a few muscles, and I'm looking at my laptop. I'm looking for these sort of changes, because if I can see these changes, it helps me to diagnose the condition. So when you look at the Escorial Criteria, the Awaji Criteria, the two criteria I showed you earlier, this nerve conduction study and needle EMG assessment are important parts of that. And really, in most motor neuron disease patients, you have to kind of do this. It's very important. A lot of people ask me, well, doctor, is it possible to have an MRI scan done? Because we know in neurology, a lot of people, have MRIs for a number of different conditions, whether it's strokes or migraines. Unfortunately, in motor neuron disease, it's not very helpful. So there's really no diagnostic marker on an MRI to help us one way or another. Very rarely you might see some brightness in the motor tracts, so that's the tracts involved in controlling movement, but that's unusual. So if we do send patients to have an MRI scan, and usually whenever I see patients in my rooms, I always get them to have an MRI, it's because I want to make sure there's nothing else. So it comes back again to this argument that really in motor neuron disease, it is a diagnosis of exclusion. You have to do every other test and make sure there is nothing else that can explain the patient's symptoms. And an MRI is an important part of that. This is an MRI scan of the brain, but we also commonly do MRIs of the neck and the back. So the MRI of the neck could account for your arm symptoms, the MRI of the back could account for the leg symptoms. But if we do the MRI and we don't see anything else, it kind of pushes us more towards MND. If we find there's slipped discs, pinched nerves, and I'm using the colloquial terms here, you've all heard of pinched nerves and slipped discs, then that could suggest another process, whereby there's something else going on. We may refer you to a neurosurgeon, you may have an operation, and then you get better. So it is important. It's an important test, but it doesn't help us diagnose MND, but it can help us exclude another disorder. Motor neuron disease, I don't really need to speak to this audience about why it's important to diagnose motor neuron disease. We all know it's very important, and it's important for a number of different things. It can result in a fairly rapid development of physical disability. We hope not, but I think it's important that the family can prepare, and so it's important to get the diagnosis right and get the diagnosis early. It can negatively impact people's quality of life, and it can place a tremendous strain on families, and that's why I think it's important that we have associations such as MND New South Wales to help. It really is important from an educational perspective, because I think all of you can relate to this, that you'll all have people who or you may know of people who've got Parkinson's disease, who've got dementias, but the moment MND comes up, sometimes you're at a bit of a loss. There's really no one else you know of, there's no other family members who've gone through it, and there's this unknown. So it's very important we have associations like this, we have meetings like this where we can educate people. Because it's not just the person who's going through the motor neuron disease, sometimes it's the people around them that need the support to understand what's going on, to understand how things may change, and to understand how they can make a difference in the patient's care. The mainstay of treatment at this stage is with a medication called riluzole. But there are some developments in this field, and I think over the next 5 to 10 years, I'm certainly hopeful that we'll see some changes. And I'll speak to you a little bit about that, but I've been going to the International ALS Symposium every year now for the last 2 years. I'm going again this year in Dublin. And the wealth of knowledge that comes out of these meetings, the new trials, the new medications that are presented, it certainly is very promising. So hopefully it is very much a question of watch this space. I hope that things do change in the future in terms of treatment. And the supportive treatment also is very important. And I'll speak to you more about that as the presentation goes on. So in terms of the symptoms of motor neuron disease, there are a vast array of symptoms, and I'll spend some time and go through this. So patients can complain of cramps and muscle twitches, and you remember we spoke about upper motor neurons and lower motor neurons. At times this could be a manifestation of lower motor neuron dysfunction. The cramps can be painful, so it's important. It is important because this is a real phenomenon in patients, and especially in patients that have upper or lower limb involvement. Speech changes can be seen, and again, if patients were presenting with the bulbar form of the disease, this can be seen fairly early. So it could well be that the speech becomes a little bit slurred. There's an altered speech quality, so family members and friends will say, look, the speech doesn't quite sound the same as it did before. And I think, however, in terms of the most common complaint, it's usually that of weakness. And when we say, or when we talk about weakness, it really can take a vast variety of possibilities. Sometimes patients will tell you that, things feel heavy. Their arms and their legs feel heavy. They may have a limited range of movement. They find they just can't quite get the arms up, but they may attribute that to shoulder problems. They might say, look, I've always had a bad shoulder. It's now getting sorer with time, and I just can't quite lift the arm up. But really, it could be because of the weakness that's causing that. In terms of their leg symptoms, they may have an unusual walking pattern. So before, it may well be that their walking was always okay, but as one leg starts to get weak, they start to walk with a limp, or they start to slow down with their walking. Some patients will complain that they give way. So a knee may give way, or when they're holding on to objects, sometimes it's just too heavy and they have to place it down. And it's usually, again, because of the weakness. But you can see how, for some patients, they may put it down to the arthritis. So if they've got a very bad knee, or if they've got a very bad ankle, their legs can give way, and they've attributed the symptoms to something else. So it is important that when we see patients, especially in the rooms, we ask about this wide range of involvement in terms of weakness. And when patients complain that their hands are involved, commonly they'll say that they can't quite do the fine precision movements, doing up buttons, using cutlery, knitting and sewing. These can all be affected. And so these are all real findings in terms of weakness. Again, in terms of the bulbar symptoms, swallowing can be an issue, so patients find it difficult to swallow. They may have a few episodes of coughing or choking when they're eating, and this can be, uncomfortable for patients, and it's an important symptom to ask about. We may find that at times patients have to change the texture of their food, so they're not just eating, steaks and lambs, and they have to change the diet to enable them to eat something that's more softer in nature. Shortness of breath can be seen, and if that does occur, it's because of respiratory muscle involvement, so it's an important symptom to ask about. At times, people may not volunteer that information, but if you ask them, how many pillows do you sleep at night, they may tell you that they have to sleep on a number of pillows because they sleep flat. They find it's very hard to breathe. Furthermore, when you ask them, well, how much do you need to do before you get short of breath? May tell you, before I used to go for 1 hour walks, 2 hour walks, but now after 5 or 10 minutes, I need to have a bit of a breather. And that could suggest that, there's some involvement of the respiratory muscles, and it's an important symptom to know about because it's something potentially we can treat with treatment. And I believe this last sort of group of symptoms, mood changes, it is an important constellation of symptoms. For a long time, we have known that motor neuron disease was related to a form of dementia called frontotemporal dementia. Now, I'm not sure how many people are aware of that in this room, but that link is now becoming more concrete. And it's becoming more concrete with discoveries made in genetic advances. And now we very much know, or we're very much aware, that motor neuron disease and this form of dementia, frontotemporal dementia, really lie on a continuum. So for some patients, they may present with the motor complaints. Some patients may present with the cognitive complaints, and then in between you've got this overlap. And it's important. It's important to know, again, not just for the patients, but for the carers around them. Because this is something the carers may note with time. So you might find that patients' personalities changes, and they change in a pattern that's called frontotemporal. So in the sense that the personality, a lot of motivation, is driven by the frontal part of the brain. And when that part of the brain gets affected, patients may lack motivation, they may become apathetic, and when the temporal parts of the brain are involved, they become a little bit more forgetful. So it's different to Alzheimer's dementia. There are some subtle differences, and the main difference is that the personality, the drive, the motivation may be involved. Again, I suppose I'm trying to educate everyone here. I'm not saying this is something that occurs in all patients, but it can be seen in some. Rough estimates have put it in about 30% of cases. So it is important to be aware of, because over time, not only is it challenging to deal with the weakness, but you've also got to try and juggle these symptoms as well. In terms of assessing patients and scoring their functional sort of outlook in life, these are the main questions that we tend to ask. So usually when we see patients at the St. Joseph's Clinic at Auburn Hospital, we would usually score them on these scales. And then over time, we get a rough idea of how things are changing over time. So we'll ask about speech. Patients may find that they have increased saliva in their mouth, and that's because there's difficulty with swallowing saliva, so you find that there's more saliva that builds up. In patients who do have a bit of bulbar onset disease, they may get a bit of dribbling, so at times they may have to carry a handkerchief around. They may have some difficulties with their swallowing, so they may have had to change the consistency of their meals. The handwriting may become affected, and again, that comes down to the precision movements that are affected with the disease. In terms of getting changed, it may take them longer if they're very stiff. Getting the trousers on can be difficult. Doing up buttons can be difficult. They may need assistance with some of these. They may also find that there's difficulty in turning in bed. So because of the stiffness, they can't quite move around as easily as before, and at times they may need to rely on holding onto the bed sheets. Other times they may be relying on the person sleeping next to them to help push them. So these are all important questions to ask. The walking and the climbing of stairs obviously will start to get involved if patients have difficulty with their legs. So it's an important complaint to inquire about. And also you want to try and act on it early on so that they've got a walking stick or a walking frame. Because what you don't want is to sort of let these symptoms go, have a fall, and then deal with the complications of the fall. So really with all of these symptoms, we can make some changes. We can suggest some amendments. So it's important to ask about. The shortness of breath, the orthopnea refers to lying flat at night, and the respiratory insufficiency deals to the supportive treatment. So if patients say that they go to bed and they wake up the next day and they don't feel refreshed, or when they go to bed they're constantly short of breath, there are things that can be done. So generally in the motor neuron disease clinics, or if patients living outside of those clinic areas, a referral to a respiratory physician or a lung doctor is very important, because with certain treatment at night time, such as wearing a mask, we can improve the oxygenation of the blood and allow patients to have a more restful sleep. So a lot of people, I think, will know about obstructive sleep apnea. You know, people are wearing their masks, their CPAP masks for obstructive sleep apnea. In a way, we're using a similar sort of a device, a BiPAP device, to again maintain adequate oxygenation at night time, thereby allowing patients to not feel short of breath at night. So in terms of motor neuron disease, it is predominantly a system that involves the motor pathways. And again, this is a slide or a concept that I like to put forward to the junior doctors when I'm talking about the disease, because with the condition, you could have involvement of any of this pathway. So really, when we talk about the motor system, it all starts at the level of the brain. It all starts at the motor cortex all the way up here. And there's a layer of cells there called the pyramidal cells or the bed cells. And from there, they send off their projections down through the brain. So then it goes through the basal ganglia, the brainstem. You may know about this because if patients have strokes in different parts of the brain, then you'll start to see a pattern of abnormality depending on where the stroke is. So like that in motor neuron disease, if there's involvement of these pathways, depending on where the burden of the disease is, you'll see a particular type of picture. The motor pathways also go through the spinal cord, and that's a very important part of the disease. And then they sort of come out as nerve roots. In motor neuron disease, that's where it stops. So the disease is sort of predominantly confined to the upper motor neurons here in the brain, and I used that term earlier, and the lower motor neuron at the level of the spinal cord. Outside of that, it's probably another condition if it is involved. It could be a pinched nerve, it could be a muscle disorder, and this is not motor neuron disease. Motor neuron disease really is involvement of the motor cortex and the spinal cord. And this is important, again, when it comes to therapeutics. If you want to try and design a drug, this is the pathway you want to try and target. Looking at pinched nerves, that's not really going to fix the problem. Looking at muscles, again, it's not going to fix the problem because it's not the difficulty with the muscles per se, it's the nerves that are controlling the muscles. And that's where motor neuron disease, the challenge lies. Because a lot of people will come and ask me, can I exercise? Can I work out my muscles? Of course you can. It's important to do that. But it's important to know the problems aren't in the muscles. It's the nerves, the neurons that are controlling the muscles. And that's the challenging part of the disease. So depending on where in the axis, the neurological axis, that the largest burden of disease lies, in a way dictates what patients present with. And this is very much something as neurologists we try and pigeonhole our patients into if we can, because it's important. Some patients will present with a combination of both the upper and lower motor neuron features. So that's something I've put forward in a few of the slides before this. And when patients present with that, that's classical motor neuron disease. We use the term ALS, amyotrophic lateral sclerosis, interchangeably with motor neuron disease. And ALS is the classical type, where you've got a combination of upper and lower motor neuron features. But then on either end of the spectrum, you can have other conditions. So some patients may present with a very slow disease, where there's predominant involvement of the lower motor neuron system, and that's a condition called progressive muscular atrophy. It's important that we make these distinctions because there's different prognoses. On the other end of the spectrum, patients present with brisk reflexes, spasticity, and upper motor neuron features, and they're called primary lateral sclerosis. The distinction is important because when I was quoting figures of 3 to 5 years, and we never like to quote figures, people will always ask me, and I never like to say what the time frame is because one, we don't know, and two, because there's subtleties in this continuum. If you have the disease more on these ends of the spectrum, it could be 10, 15 years. Okay, so it is important that these subtypes tend to do a little bit better than the classical form. But unfortunately, the statistics are such that most people have the classical form and the rarer forms are 10 to 20%, but it's still an important part of motor neuron disease. And then you've got this sort of other continuum where patients are presenting with motor neuron disease and frontotemporal dementia. Sometimes we may not see them in these sort of meetings because they go more to the dementia type associations if they've just got the dementia. But very rarely in some of those patients, they may have some weakness, but it's subtle. So people don't pick up on it. If you really examine their strength, they might be a little bit weak, but the vast majority of their symptoms are more dementia. So it's a different sort of referral pathway. They don't generally come through to us. They go more and see the dementia doctors. A lot of people, I suppose, ask me as well about motor neuron disease and how does it start? Where does it begin? We don't really know. What we do know, and a study has suggested that the disease may be triggered by 6 different factors. This was done with mathematical modeling. No one really knows what these 6 factors are, but it could be a combination of genes, environmental factors, infectious factors, lifestyle changes. For example, we tend to find that patients who are soccer players, who are more fitter, have a higher incidence of motor neuron disease. Generally you sort of seem to think that it's in diabetes, for example, it's the patients that are more obese, who have high cholesterols, high blood pressure that get the disease. But in motor neuron disease, in a way, it's sometimes the opposite. It's those that are fit, that are active, that are cyclists, that are joggers, that tend to get the disease. And there's a number of theories put forward as to why that occurs, but no one really knows. But it's an important point to note. So patients may be born with a genetic predisposition. They have these different exposures during their lifetime, and then they get the disease. And I'll speak about cortical hyperexcitability later on. So again, this sort of summarizes that concept again, that patients could be born with certain genetic factors that predispose them to the disease. And then you've got these environmental factors, maybe inflammation or infection, that then triggers the disease process. The challenging aspect to us, I suppose, is that when we tend to see patients, we're seeing them at this stage, but already there may have been some damage that's been sustained. And I think that's the difficulty. So in sporadic motor neuron disease, we don't know who's going to get it. And by the time they get it, we're kind of catching it pretty late in the piece. And that's why we haven't really got any effective treatments to get on top of it. If we can identify the changes much earlier in life, then it's easier because we can try and address it at that stage. There are three schools of thought in terms of how the disease may begin. Some people think that the disease begins in the brain and then spreads down. That's called the dying forward hypothesis. Some think it may well be a combination of the brain and the spinal cord. That's called the independent degeneration. And then others have wondered whether it really starts at the spinal cord and goes up. From the research that we've done at Westmead, we sort of tend to think this really is a brain disorder. I think the disease really starts at the level of the brain and then spreads down. And that's what makes it challenging. Because if you're going to try and treat it, you've got to try and change something up here. And that's harder to do. The pathophysiology is very complex. Whenever you put up a slide like this, and it's even in a medical meeting, the audience members usually generally know this means you don't really know what's going on. I mean, to a certain degree, we're learning about this, and we are trying to crack the code, if you like. But there's so many different things that are going on. There's still no clear picture as to what the most important part of it is. But what we do know is that riluzole, the only drug that we use to try and change the disease course, works by blocking an excitotoxic neurotransmitter. So there's a neurotransmitter or a hormone that's called glutamate, and riluzole tries to block this glutamate. We think that there's an excess of glutamate that then mediates neuronal death. It's basically causing the neurons to die. So we try and block that if we can. But there's so many other aspects to the disease process, we really need to try and figure out the most important parts so we can try and block the appropriate pathway. So familial ALS accounts for about 10 to 20% of all MND patients. I won't go into it in too much detail because Kelly is going to speak about this after this presentation. It's important because the most common gene was only discovered about 3 years ago, and that was the topic of my PhD. So the gene was sort of discovered in 2011. I started my PhD in 2012, and it was all very topical. It was relevant because this gene linked both motor neuron disease and frontotemporal dementia. This gene accounts for almost half of all the familial cases of MND. So it's a very important discovery. It's important because it shows us that MND and frontotemporal dementia are similar. And we've, in a way, cracked the most common cause of genetic MND. That's why I think these are interesting times because we're evolving. We're learning more about the disease. So say in the 1990s, we only knew about 20% of the cases of familial motor neuron disease. Now, 2014, we can account for almost 75% of all familial cases. So there's not much left to find in terms of familial MND, but for the sporadic, which is the important aspect, we still don't know, and that's the challenge. So a lot of the research that I do is looking at, this dying forward hypothesis, looking at cortical changes. This is me studying one of my colleagues at Westmead, and we've all been volunteers for the study. In fact, we're always looking for people to volunteer to help us with research. So I'm going to hang around here till lunchtime. So if anyone's willing to participate in research, please come and see me. Not only are we interested in people who have motor neuron disease, but we're also interested in healthy carers as well. So when we try and publish the data on the research, which we should do to try and increase the knowledge amongst everyone, it's important that we compare like for like. So if we have motor neuron disease patients, but I'm the healthy volunteer, my age and their age is not going to match up. So we're always interested in healthy volunteers to help us so we've got similar age groups. We utilize a magnetic test, and then we sort of stimulate at the head, and we're recording a little twitch in the thumb. And by doing this, we generate these sort of curves. And what we've showed, importantly, is that this phenomenon of cortical hyperexcitability precedes the disease in genetic ALS patients. So whilst the genetic ALS patients only account for about 10 or 20% of the disease, they're important because we can use them to try and learn how this disease switches on, how this disease comes over time. By following up carriers who have the gene but who don't have the disease, which is what I do as part of my research, every 6 months I'm doing this test. Every 6 months I'm looking to see, are there any changes? What's getting switched on first before they get the disease? So these genetic carriers are very important. We've shown that this is a very early phenomenon, and this was a paper that Kelly was also part of with the FUS mutations. We've looked at one of the mutations, the SOD, then we've looked at the FUS. Then, I published this paper last year looking at the C9OFF, which is the most common genetic mutation, showing that in all of these cases, we tend to see this feature of cortical hyperexcitability. So whether you have sporadic ALS or genetic ALS, in respect to any mutation, you tend to get this brain abnormality. The disease really seems to involve the brain. We've also shown that by utilizing this test, that we can diagnose patients earlier. So in a lot of the patients that I see in my rooms or at Westmead, I might tell them, look, please come and help us out with research. But I think it's also important because we might get some clues. So whilst it's not a Medicare rebatable test, obviously we don't charge patients, we see them at Westmead, we do this test to try and get more information. So I've mentioned to you that MND is a challenging disorder. We need as many clues as we can get, and this seems to be a useful test to use. When we've looked at patients who've taken riluzole, we've shown that there's changes in this brain activity. So the riluzole does make a difference. It does seem to reverse this phenomenon of cortical hyperexcitability. So whatever this phenomenon is, it's a real phenomenon, and that's what's improved with riluzole treatment. So it's a real effect, and this magnetic test seems to be very helpful. So going forward, the questions are, can we use high dosages of riluzole? We can, but there's no evidence to suggest it really makes a huge difference. Could we use it at an earlier stage? Potentially. So I think it is important to try and diagnose patients early and get them on treatment as early as we can, although there are a few months of delay in the process. We really need more effective treatment strategies, and I think that's what we know. Riluzole is a good drug, but we need something that's stronger. But perhaps by utilizing the magnetic test that we're doing at Westmead and also at RPA, we can try and measure changes with other medications. So if other drugs come on board, perhaps we can try and look to see if changes are evident on the TMS testing, which will be good. This is just I just took this as a snapshot from one of the ALS websites, just showing how there is ongoing trials in ALS. A lot of these trials are in America, but importantly, we're also going to see some trials at Westmead, PA, and Macquarie later on this year. And I'll come to that very shortly. Multidisciplinary clinics are very helpful in managing the disease. So riluzole is the only drug that we have which can try and slow down the disease, but being referred and seen by a physiotherapist, an occupational therapist, a speech pathologist, a neurologist, a rehab physician, it's very important because they can try and manage different symptoms and try and keep patients going for as long as we can, in the best of our ability. So it is important to be linked in, and I think that's another good service that this association provides, is they can provide support, point patients and carers in the right direction, and so it's an important part of managing the disease. If patients have difficulty with swallowing and eating, we can use a peg tube. And I tell patients, look, sometimes they're very worried about the stigmata of peg tubes, but really, it may allow them to have fluids, to have something to eat, so they don't get that sensation of hunger. With the breathing, we can use the masks. With the walking, we can use things like crutches, walking aids, foot splints, all sorts of different interventions to help people and to manage their symptoms. There are a number of other drugs that we can use in motor neurone disease. I'll wrap up in the next few minutes, just the last few slides. So if patients have any depressive symptoms, we can use some medications. If they have difficulty with excess saliva, we can try and dry the secretions. If they have muscle cramps, we can use some anti-epileptic type medication to reduce the irritability of the muscles or the crampiness of the muscles. So it's a muscle symptom, but it's secondary to the nerves that are being involved. And I suppose these are probably my last 3 slides. As I said, it's exciting times in motor neuron disease because we've now got trials that are coming on board. The last 2 big trials, I suppose, finished over 2 to 3 years ago, and they were negative trials. They didn't help very much. But there's been a lot of work suggesting that perhaps a virus which lies dormant in the human genome, so in the human DNA, could get switched on. And maybe that's going to drive the disease process. We don't know. This was a paper published last year in 2015 where they suggested this was a possibility. Subsequently, at Westmead, RPA, and at Macquarie Hospital, we're going to be trying this antiviral treatment to see if it may help. So it is worthwhile to keep linked in with your neurologist, ask them about these trials, because if you're eligible, we'll certainly enroll. And it's I think, going to be an important trial because it may be a very real link that this virus plays a role in the disease process. People will always ask about stem cells, and I think this is a question that I invariably get asked about almost every time. Look, there's a lot of promise with stem cells, but at this stage, we still don't know if it works in motor neuron disease. This study has showed that, look, you can implant it in the spinal cord. The stem cells may get taken up at the spinal cord, but really, is it going to change things here at the motor cortex? So yes, you can have an injection through a lumbar puncture in your spinal cord. You can inject stem cells there. But is it really going to then navigate to the brain, go into the motor cortex, get switched on, become the appropriate cell, form the correct connections, and then try and fix the underlying problem? I don't know. And that's where the challenge lies. Anyone can sort of inject cells into the lumbar cord, through a lumbar puncture, but then how do you get these cells to switch on, perform the correct duties, and work effectively? And that's why this treatment is still quite some time away. In saying that, we would never discourage people from trying it. We've had a few people who've gone to China, who've gone to India to have it done, but I don't think there's any evidence really to say it works right now. But down the line, maybe in 5 years, maybe in 10 years, I think this could be a real possibility. So there's hope. Okay, there's hope because these are evolving times, and really there's vast advances being made in stem cell treatment. So in concluding now, the diagnosis of ALS, it's challenging, it's difficult. As clinicians, when we see patients, it's not a diagnosis we like to make. We like to make sure that there's no other diagnosis that can explain the patient's symptom. And then we do a lot of different tests. It can be a little bit frustrating, but it's because we want to get the diagnosis right. We need to make sure that there's no other diagnoses, as I've said. At this stage, there's limited therapies, but things are evolving. Things are changing. And I think in the next 5 years, we're going to see a lot more clinical trials. So in America, there's trials being done on anti-epileptic treatments, which have shown that they've helped with the motor neurons. So really, I think over the next few years, we're going to see some promising results. At the moment, we've got riluzole, but don't forget that supportive treatment can be very helpful. So I think it's important to be linked into a clinic or be linked into a service where you're getting the allied health input, the physio input, the speech pathology input, the occupational therapy input, nursing input, because all of this will help not only with day-to-day care, but also help carers to try and best manage their patients. So I'll conclude there. I know I'm a few minutes over, but we've got plenty of time for questions.